they look differently. I've never read anything about them having different grade in biopsied metastatic lesions compared to
You're
the
an
primary
orthopedic
lesion.
surgeon, so let's think about it.
Yeah.
So from a cell to go from the primary tumour to end up in the lung, what does it have to do?
It has to do so many things. It has to get into the bloodstream. It has to survive in the bloodstream. It has to get to the lung. It has to exit the bloodstream, get into the lung, and it has to be able to survive in the lung and grow. So there's a lot of steps. So these cells are
But
really...
do you think a normal cartilage cell can do that?
No.
No. So one of my premises is that the metastatic cells are probably completely different.
Okay.
And you can do that through flow cytometry. You can look at and if we look at the circulating tumour cells, we see that they're actually very different to the original cells.
Right.
So your premise is that actually controlling local disease is important for the tumour, but maybe not related to metastatic disease. This was our study where we looked at the local recurrence, and we found that 19% of patients did show some signs of upregulation on their local recurrence.
I have to say that these samples for the local recurrence, they haven't been re-examined to look for more aggressive areas, but the main pathology report has nearly always contemplated, is this similar, and concluded.
And also where we go back to that area. So this study, we did the study first where we looked at all the cells, looked for those very small aggressive cells, and we still said this is grade 2 if it was predominantly grade 1. And then we went back and looked at all the pathology again and said actually the local recurrence was grade 3 or de-differentiation or whatever, whereas yours was a lot lower. So the fundamental question, thinking about the biology that we've just talked about, the results from your thesis and other literature, does having a tumour coming back in that area, does that affect survival?
Yeah, and it looks like in our data as the whole group that it does, but if you look at subgroups, it doesn't look as though it in fact does. Another question of that is, even though we're not measuring upgrading, does the fact that a tumour is being intervened with in some way make it more aggressive? I think that has been a very common myth or accepted myth for chondrosarcoma. We keep thinking and blaming the tumour, if you like. And that's an interesting concept, and it probably takes place, but I don't think it takes place as much as we think, because if we look at how poor our tools are for assessing this, a lot of this can also be very logically explained by our tools or lack of understanding.
So this is about making you think about what you're going to do next.
Okay. Yep.
So you thought that you hadn't thought about it before, about the cells.
Yeah.
Now we're thinking about we take a tumour away and some of those cells decide to come back. Now I would say that they upgrade is logical. It's the worst cells that come back and therefore are more likely to metastasize than not. So you showed in your thesis, very nice, elegantly, that if you had a local recurrence, your survival was hazard ratio of 4 times more likely to get metastases, and you were 9 times more likely to die if you had local recurrence. So, do you think that local control is important now?
I think local control is important, but balanced, and the premise of this again is that we are the whole time trying to achieve local control. So even in the sense, I don't think we can interpret this as in saying that we don't need to worry about local recurrence and we can do lesser surgery, but I think it's about being able to handle people with local recurrence and being able to guide them as to say, how bad is this?
Okay. And you said that in your thesis, and it was the same in our results, that you can only get local control again after local recurrence in 40% of people. So why, if we take it out and you can get local control in 90% of people the first time, why can we only get local control 40% of the time in the second go?
It is about contamination and operability of the recurrence primarily.
Or biologically.
Or biologically, yeah.
So it could be that we haven't done a good job and we've spilt it everywhere. Yeah. Or it could be that those cells are worse.
Yeah.
Okay, so.
Yeah, that's true, yeah.
So I get a local recurrence. I come back to see you, and I say I've got a local recurrence again. What do you do with me as a patient? In terms of staging, what do you do investigation-wise?
Yeah. So I need a MRI CT of the area. I would re-stage systemically also with a CT of your lungs.
That's my point. You restage after finding a local recurrence, okay?
That's true, absolutely.
So that gives us two scenarios. You can find that I've got a local recurrence alone, or you can find that I've got synchronous local recurrence and chest disease.
Yeah.
How long after my local recurrence been detected do we count chest disease as separate from local recurrence to chest disease? Because in a registry data, you get registered as having local recurrence, and there probably isn't evidence at that time you got metastatic disease. Then 3 months later, you say that I've got metastatic disease. Did the local recurrence cause the metastatic disease, or was it always going to happen because they were the worst cells?
Yeah, so it's quite common. A lot of people account for time delays of plus minus 3 months or something within that definition, either in the definition or by giving it in their cohort that this was the period that it turned up. I have addressed only date-specific data. Yeah. And what happens also for the ones that appear at the same time is that they are taken out of analysis by the statistics.
So we're aware that synchronous local recurrence and metastatic disease we can't read into because we can't tell anything about it.
No.
What we're interested in is the people that get local recurrence and then do or don't develop metastases, but at some time forward. And the literature says 3 months. I think that's way too short. I think it should be 6 months, or maybe even a year, because it's very hard to know the inference of that, because there's a difference between association and cause.
Causation.
Yeah,
definitely.
And statistics can't always tell us that.
No.
So tell us about the statistics that you've used in these graphs.
So this is Kaplan-Meier curves with univariate Cox analysis.
Yep.
Yeah.
Okay, so tell the audience, I know what that means, but half people are suddenly hanging themselves in the back. Or
so Kaplan-Meier graphs, so we talked about briefly, you can choose a variable that you want to look at. They are called survival graphs, but they don't need to be measuring survival. They can measure anything. So, but in this case, it's measuring how often a tumor metastasizes, and we start down at 0.
But everybody starts at time 0.
Yeah.
We've all been born on the same day, or we all get cancer on the same day.
So you follow them from, for example, surgery or diagnosis, and you follow them in time along this way. So up here, as every step or elevation of the curve is metastasis that happens. And the blue line is the rate of metastasis in people that don't have any local recurrence, while the red line is the rate of metastasis that happens in people that have a local recurrence. Yep. And then we do an analysis with the statistics that shows that this difference is not only visual on the curve.
So I'm on the blue line. I haven't got local recurrence, and then I die at 3 years after my diagnosis. Yeah. I get run over by a bus. I have a heart attack because I'm so scared about examining you.
Yeah.
Yeah. What happens to my data?
So when you die from another cause, then you're taken out of the data. So you contribute only what we call observation time for the amount of time that you're strictly under observation. And when you die, you can't be observed. So this is a very big difference to, for example, crude percentages, where you just do the numbers and you presume that.
So if I had metastasis then, but I hadn't had a chest X-ray or a CT scan, what would the graph say?
It wouldn't count it.
It wouldn't count it, exactly. So can you think of a statistical way to try to overcome that? So what are we trying to move? We all love Kaplan-Meier, it's nice and simple.
Yes,
But what are we trying to move to?
So there's something called competing risk. And this is this is very appropriate to think of, particularly for diseases like chondrosarcoma, which the more aggressive a disease is, the less important it probably is. But these intermediate type aggressive diseases, competing risk is a way of taking into account, other than just observation time, the event of other events, for example, death in the methods. So we've talked about having to do this in the next work.
Yeah, so this is our data. Yeah. So we strongly agree with you as well. We didn't see a single patient with a truly grade 1 tumour that died. No. And that's unusual for most series. In grade 2, there's a huge discrepancy between those that had local recurrence and didn't. Yeah. For 3, for dedifferentiation, it's not as statistically significant. But on competing risk analysis, actually, it is all very significant. Yeah. Okay, so you have in your study 40 patients with local recurrence out of 380 or...
Yeah.
Yeah? Yeah. So because you get a p-value, does that mean that your sample size is big enough?
No. So sample size is a way of beforehand predicting how many people do we need to involve to find a certain amount of difference to a statistical level. Now, it's not really...
To the audience, what does a p-value mean? Yeah. So we've talked about p-values, but 5%, what does that mean?
So a p-value is, you have to basically make some sort of a cut-off point with regards to the security of your findings. Yeah. So a p-value at 5% is basically saying the same as that there's a 95% chance that the value that you have is within the confidence interval or the range that you have.
So what that means is a 5% chance we're wrong. Yeah. Yeah, we think that it's right, but we're wrong. Yeah,
absolutely.
Yeah, and that's based on what we call type 1 error, yeah? So what's a type 2 error?
Is type 2 error selection bias?
So it's saying that something's wrong when it's right.
Right.
Statistician?
It's the
talking about now. So that's the whole reason why we do sample sizes before we do it, and that we can't do that with retrospective data.
No.
So I'm not saying what we're finding is wrong, but in our series 300, 400, 700 in the other one, I'm not sure. We then have to say what's a clinical meaningly difference. Is it 20% or is it or whatever it is? So in everything we do, it's not like doing a randomized controlled trial for chemotherapy where we set all these figures at the beginning, yeah? So we have to just be aware of it. Definitely. So Oslo classification, the best thing, or the thing that you're proudest about, okay? So you've changed it into practice, which is excellent. You've got results you're quite confident about. Let's just go through the graphs. So rate of metastases by top left, axial stroke extremity. So axial's bad.
Yep.
Yeah.
It's bad, but it's not very specific.
Yep.
Yeah.
Okay. We haven't got time to go into that.
Yeah.
Top, the one on the right, top right is the one that I'm most interested in. Yeah. So if I've got a soft tissue mass, but it's in the axial skeleton, and it's less than 1 centimetre, so it's broken out the bone, so it's by definition aggressive. Why don't I get metastasis from that?
Well, we don't know. To be fair, we talked about this. What is this size variable, and what does it mean? Whether this is just this is most probably a staging tool, and it's just saying, is this not? Are we catching something at a time when it's not as aggressive?
Top right, bottom left. Look pretty similar to me.
Yeah, but the interesting...
Could it be that the ones that got a small soft tissue mass are lower grade, rather than the ones which got a big soft tissue mass which are higher grade?
In part, but the interesting thing is that we have low-grade tumors, grade 1 tumors in the high-risk group, and in the low-risk group, we have high-grade tumors. Yep. So, but is maybe this in some way selecting the grade patients where
so
it's relevant?
Is this univariate or multivariate analysis?
This is univariate.
Okay,
yeah,
so at the moment we're taking one factor and looking at it.
Yeah.
So what could we do to find out if that's real or not, whether it is grade or whether it's the Oslo classification?
we can enter it into a model, either stratifying it with another variable at the same time, or in a larger statistical model with multiple variables.
So more numbers, multivariate analysis, or
validate data
and competing risk analysis, yeah?
Yeah.
Because competing risk would take those risks. So when we collaborate and we validate it, then we should think about doing that, yeah? The one thing that on this one that I just wanted to look at again is I'm worried about this low risk 2 group.
Yeah.
And yes, you've got some nice statistics. On overall survival here, it looks significant, but on disease-specific survival, it doesn't look. But what should we do if I was you applying for a multi-million-pound grant? What would I want to see on there? What would you put onto your survival curves?
I would definitely want to, as part of any additional grant, examine that group further.
Yeah.
I don't think that is in a particular an area, and in a way I'm glad that I started off with these subgroups of low risk 1, 2, 3, and then in the end I had to present the paper with low risk, high risk, because you can't fit everything in, but that's the group I want to investigate.
We've got a p-value of 0.15, that means there's a 15% chance of us being wrong, but what people don't think about when they're doing this is a 15% chance of being wrong to that, not to that.
Yeah.
Yeah?
You have to take in mind what it's being compared to.
Exactly, yeah. So you'd want to see confidence intervals and all those sort of things, yeah. Okay, good. So does navigation make any sense in chondrosarcoma?
It does, absolutely, yeah. In particular, your study of the pelvic periacetabular cases in particular shows us that the resection margins in bone are less, and I can't remember whether the statistics of the survival group was better, but it was at least improved, and you got a big reward for that just a few days ago.
Yeah, thank you very much. You've done your homework. Thank you very much. So we think it is for lots of reasons. In this paper, we showed that we could get lower local recurrence and navigation, intralesional rates. This one again, we showed that we got lower local recurrence and less intralesional rates. That was the original paper. And I want you to, after today, for your future research, think about your relationship between local control and the cells and what we do as a surgeon to try and make it better. Yeah. Because this was a paper with 5 years follow-up that showed that the disease-free specific survival with chondrosarcomas, and the reason why we chose chondrosarcoma is because it's only surgery it's treated with, so there's no chemotherapy to get in the way.
It's the easiest to study in some ways.
It's the easiest thing to study. It's the most understudied of the primary bone tumours because there's no chemotherapy that is given to it currently. Yeah. And therefore it's pure data, yeah? So this is one intervention for the 2 groups, and we showed that there was a 23% survival advantage in disease-specific survival. And if you look at progression-free survival, even much higher. Yeah. And that is only by altering one thing, by not being in the tumour and being far enough away. Yeah. So if your Oslo classification, which I think is incredible, could be translated into the clinic, and we can prove it, then we can start to say we don't need to operate on this one, and if we are going to operate, let's just bloody operate properly and do it right.
Absolutely.
Okay, good.
And there's no doubting that local control, if you need to operate, is key and vital. Yeah,
and I would suggest, though you don't agree with me, but that's fine, that it's because we keep those cells, we don't. And there's a famous philosopher that said, there's no point having a mind unless we change our mind sometimes.
Absolutely.
All right? Yeah. Okay, so...
I am worried when that is said that people will interpret this as to saying, well, local recurrence doesn't matter. That is not what I mean to communicate.
So that's what we need to communicate. Yeah. So you have 5 more minutes left. Yeah. This, oh, sorry, it's jumpy. I don't know why it is. So this is a 52-year-old gentleman that works on a submarine. He's got a predominantly interosseous chondrosarcoma, periacetabula. Tell me how you're going to investigate and treat him. So you've done your staging, no Mets.
So he's no metastasis, and our radiologists are happy that this is a cartilage signal.
Are our radiologists happy that this is a cartilage? Yeah. Oh, bugger. Damn.
So
it's going so well.
In that state, and he has a soft tissue component. We've got a good definition of the anatomy. The hip joint is not, it's not open into the hip joint. For the sake of the discussion, then I would talk about him. I would say you're 52, you need surgery. There's not an option. You're not 85. We can't follow you. We need to do this, but there's no rush.
Get back to working on a submarine. So are you going to biopsy it?
Yeah.
Yeah. No, you're not going to biopsy it.
Yeah. I'm not going to biopsy it. I'm going to go straight to surgery.
You're going to take out half of his pelvis without buying it.
Yeah.
Are you crazy?
Yeah.
The lawyers. Where are the lawyers?
Yeah.
Okay.
And that is, for a period, we've been biopsying things because we're doing axial surgery, and we say that the morbidity here is high, so we need to do it.
Okay.
And that's an argument, but in my mind, if the biopsy isn't actually telling you what you need, then it's unnecessary and confusing.
I was going to ask before, what are the consequences of biopsy? So something we're studying at the moment, because we're trying to prove that it's safe not to biopsy. So we've got a piece of work going at the moment.
Fantastic.
But what are the consequences of not biopsying stuff? So we've said about possibly microcontamination, probably not important.
Probably not.
But what else can you do? You delay the patient.
Yeah.
Probably not important.
Although for needle biopsies the risk of complications is very low, but in theory you can get an infection.
Yep.
You can introduce bacteria into an area where you want to put an implant.
Yeah.
Yeah.
Okay, and the other thing is post biopsy fractures, which in fast-growing tumours is not uncommon, probably only 10%, but dedifferentiation, we see them fracture quite a lot before. Okay, so back to this case then.
Yeah.
So what are you going to do for him then?
So for him, I would probably say that what we need to do is surgery. We need to plan your surgery. In the current technique of things here, he would be a good candidate for printed resection guides, printed prosthesis.
Okay. What margin you plan to take?
We would
So it's only in the bone?
Yeah.
A little bit of edema there? Michael, has that edema got cancer cells in it?
No.
Yeah.
I think what we would generally, planning takes a bit of time as well, so it depends on the anatomy where you are, but we would plan on about a centimetre for that to be able to ensure that we get the millimetres that we need.
So it's quite quick, but it's got some edema around there, so the next thing from a surgeon is that cancer or not? Yeah, so that's what we did. Exactly right. Bone margins, what are you going to plan for him on?
So this rehabilitation obviously is demanding.
No, margins. When you're going to cut it out, how much of the space on the tumour?
During the planning, if tissue allows it, you've got to think about you need enough bone for a good fixation. You've got to take all of this in advance. We would probably plan for about a centimetre to allow for the sort of uncertainty of growth and.
So it's like that guy with the plane before. Just because you can get close to it, we shouldn't.
Yeah.
The sources of error in navigation: 1 millimetre for registration error.
Yeah.
2 millimetres for thickness of a saw blade.
Yeah.
That means that we can be 3 millimetres out. So we need to be at least 5 millimetres away.
Yeah.
Because we might be as close as 2 millimetres. Yeah.
Yeah.
Okay. There's your ingrown surface, some jigs like you showed earlier.
Yeah.
There's his reconstruction. Yeah. All very pretty.
Yeah.
And this is the guy. Oh no, doesn't like when I do it together. 5 months. My patients are sick of me emailing them.
Yeah.
And then you can use it in all sorts of other places as well.
Yeah.
Okay. So I wanted to finish up by asking you one question.
Okay.
And you've got 1 minute.
Okay.
So you said you're not going to follow people up after 5 years.
Yeah.
And 50% of the cases are local recurrences are asymptomatic, so it's worth following people up.
Mm-hmm.
But then you do a CT scan of the chest and you find they've got multiple chest metastases. What can you do about it?
The chest metastasis is very bad news. It is all about surgery or not so, the number of lesions, and the speed of growth.
Yeah.
Like I said, we do not have any patients that have survived metastatic disease. We have probably not been particularly aggressive in their care, I think. But again...
so should we do an investigation if we can't do anything about it?
That is a very good point. I think we don't do anything about it, of course. So it is about, I think if you've got patients in their 80s, for example, where they're not going to do thoracotomies at all, then I think that is a very good discussion to have with the patient. But I think people also have an informational requirement, say I'm full of metastasis or I'm not full of metastasis. So you need to...
and we do something about it. The oncologist will give them palliative chemotherapy.
Yeah.
There's a nice slide that I use in talks that says you have 6 months to live, but we can make it feel much longer.
Yeah.
So, on that dig, I want to say thank you very much for asking me to challenge your thesis. I thoroughly enjoyed reading it. And if you look at Steve Jobs' quote, I think one of the most important things is that hopefully you decide that you're going to use this knowledge and it will inspire you to do much more greater things in the future. Thank you very much.
Thank you.
Thank you so much. And now I think we're going to have a short break, hopefully a short break. The committee is going to retire to decide if they're happy with your defense. And then they will come back and announce if they're happy. So we take some minutes and you can go out and have this discussion. Nei, du skal være her da. Du skal være her da.
Var det ikke helt skjønt det?
Nei, du kan bare bli her da.
Ja, det bra. Det var gøy da. Det var gøy.
Du får jo vente og se da.
Altså, men det var nå likevel veldig moro. Har dere holdt dere våkne? Ja, så bra. Ja, så bra. Tusen takk. Det er veldig gøy. Dette har jeg gledet meg til veldig lenge. Ja, ikke så mye. Mest gledet meg. Så det var gøy, men vi fant jo fine folk som var interessert i å se på det med åpne øyne, så det er veldig gøy. Så kult. Det gjør jeg absolutt. Det vi ikke fikk fram tidligere er at eksperten på SI-leddet, en internasjonal ekspert på sakroiliak-leddet som vi snakket om i bekkenet, han står her. Ja.
Jeg synes det har vært litt for lite fokus på meg i dag.
Ikke sant? Så det er veldig mye spennende kompetanse i rommet, altså. Så er det så mye spennende ting vi kan finne ut av sammen, alle sammen, og det må vi bare tro på. Hva sa du? Nei, det var det. Det merker jeg er et problem, så det... Ja, det er bra. Ja, så bra. Det er en fin gruppe. Hei, jenter! Jeg tar bilde av dere, eller? Nå kommer de.
Okay.
We'll take more.
Okay. everybody was happy. Yeah. Okay, so it seems like the committee is happy with you, Joachim. So I have to congratulate. We will send this to the faculty today. Perfect. And on the behalf of the faculty, I would like to congratulate you and thank the committee and the opponents for a really interesting day. And I also will congratulate the supervisors and, of course, the family that has been there with you and all your colleagues. And hereby I will declare this public defense for concluded.
Perfect. Thank you.
And if you have some final remarks, you can come with that now.
I'm so happy. I so sincerely want to thank the university for allowing me to defend my thesis. I want to thank you, Thomas, for hosting us today and doing a great job. I want to thank so much Kjersti for organizing and taking care of the committee, and Professor Jays and Dr. Skorpil. Thank you so much for reading all my thoughts and pages and coming here to have such an open discussion with me. It's been an absolute joy, and I'm very, very grateful. Thank you. Yeah. Da skal jeg gå ut.